Yes. Hello, Tashi.
The mute. It's okay?
Yeah, hi, I can hear you.
Yeah, I can hear you.
Good. Good. Where are you? Is your picture on there or no?
Picture. Okay, I will show the picture. Okay.
Okay, how you doing?
I'm doing fine. I'm fine.
Okay, listen, yeah, Louis Barber wants to translate his webinars with Al, you know Al Mefti?
Al Mefti, I know Al Mefti.
Okay, it's a series of conferences. Here, let me get the banner up. Here, hold on.
From February 19th.
It's more than one. It's like 6 different ones.
Right, 6. Okay.
We'll talk and let me just show you, and the panelists can look at this too.
Okay.
To see if they're interested in it.
Yeah, I'm very interested. Is it a skull-based surgery?
Yes.
Over.
Yeah, the best.
Yeah, the very good one.
Here, oh, here we go. Okay. Okay, we make a nice banner. Morlick's made a nice banner already. See that, huh?
Yeah.
So he's doing a series. It starts the 19th, but it goes for like 6 to 12 weeks. So once a week. Well, I think on Thursday. I think it's more than one presentation, but I'll let you know as the details come in.
And is it February 19th will be Friday?
That's a Thursday.
Maybe Thursday. So that'll be Friday morning.
For you, yes, from Brazil. Yeah, this is from Brazil.
Yes.
So
GMT plus 3. So the time zone will be 10 a.m.
Yeah, Brazil. Yeah,
in
Brazil
Japan.
time. It's Brazil time. So
just
okay. Oh, let me check. Okay, so we'll talk later. Okay.
Okay. So
any problem, just text me. You can text, right?
Yeah, I can text it.
You can text in Facebook, or if you want to text here, it's okay.
Okay, so I can use the Facebook.
So you're okay. I might introduce you. Do you mind if I introduce you?
Yes.
Yeah, I'll say we're also translating this into Japanese. I'd like you to meet Dr. Takashi Kan from Tokyo.
Yeah.
Okay. Okay.
Tokyo. Yes.
Where you from?
Yes.
Tokyo.
Yeah. And Tokyo. Yes. Tokyo.
Okay.
Showa
Okay.
University. Tokyo.
Okay. See you.
Okay. Japanese here. Talk in Japanese here.
I'm sorry. Are you talking to me? You're echoing.
Yes. Echoing. So, do I have to talk here in Japanese?
Oh, no, that's okay. No, you can talk in English. It's in English, the presentation. So, or you can say in Japanese. I don't know. I don't know what you're referring to. I'm sorry, you're echoing. I can't hear you.
Yeah.
Maybe it's better I don't introduce you, okay? I don't want to make it complicated.
Okay.
Yeah, it's better I don't introduce you. I just say it.
Okay.
Yeah, I don't want to cause problems. Okay.
So
now all we need is for you to and Ben to show up.
Oh.
No, they'll come, but I get nervous. Oh, let me check let me change my background there.
Yeah. So should we use mute?
No, it's okay. You don't have to talk. Takashi, can you hear me?
Yeah, I can hear you.
Yeah, you're on mute, but I can still hear you. Why is that? I think you may have two microphones.
I opened both, so
okay.
computer and iPad. So I will either I will leave either, and it's okay
Yeah,
to
you're breaking up. I really don't hear you.
So that's why double. Okay. Is it video here? And then
I'm sorry, I can't understand you.
like this.
Oh, you're on two screens. Okay, I see.
It's a.
I can hear you.
Should I open two screens? Should I open two screens?
Wow, is my clock right?
Should I open two screens?
I'm sorry, I don't hear you well. I think you better text because it's very garbled.
Can you hear me?
Yes, I can hear you now. I can hear you.
Okay. Okay. So like that. And that is it okay to?
I must. I must mute you because if you make noise, we don't want to hear the noise. Yeah, like for example, yeah. I've got to mute you. I've got to mute you because not now, but once we start. Because if I don't mute you and you make a noise, the camera will go to you. So. I hope they show up. Man.
Yeah, Dr. San was late.
I'm getting nervous. So how are things, Takashi, in Japan with COVID?
No, the patients are increasing.
Increasing?
Yes. However, severe patients are less than before.
Oh, okay. Now,
Only
well,
only the PCR positive patient.
They're starting to give the vaccine here to doctors.
Yeah. Yes. Yeah. Yes.
So first they start with nurses, doctors, and they go from there.
Yes. Go from there. Yeah, and stay at the hotel. But still, the Tokyo, some subways are crowded.
The what's crowded?
Subway and trains.
Oh, crowded. Really? They're crowded? Oh, really? So nothing changed.
Yes.
Now it's back to same, back to
nothing
normal.
Changed. Nothing changed. Nothing changed.
Oh.
But only except everyone using a mask. However.
Right. Well, before in Japan they used masks, so no big difference.
Yes.
Yeah. But not before. But before everyone doesn't wear a mask before, right? Just pollution.
To avoid pollution and the allergic in spring.
Oh, okay.
Yes, pulse allergic. So every April, most people use masks. So a few difference.
Oh, okay. Okay. Yeah, I have some brothers that went to Japan to play hockey. Ice hockey. Ice hockey. Ice hockey.
I know.
Yeah, in the north of Japan, the north.
Hokkaido, north.
Yeah, Sapporo, near Hokkaido. Sapporo.
Near Sapporo.
Yeah.
Maybe Hokkaido.
Yeah. Yeah, they like it there. They like it.
Yeah.
But they like meat. They like meat. and that's one thing. They didn't like fish too much, you know.
The fish.
No,
Japan
they're meat men, not fish.
Meat man.
Fish. Yeah.
Not fish. Meat man. Okay.
Right. Yeah. That's how they're raised, you know. Okay, let me check with Juha, see what's going on here.
Okay.
Oh, wait a minute. Okay, folks, are a little late connecting. Hang in there. I just wrote to you on WeChat. Oh, yeah, that's what, as you know that. Do you use WeChat in Japan?
Which?
Do you use WeChat in Japan?
WeChat. Sometimes we use, but we seldom use it. We use the line, WhatsApp.
Okay.
Some use WeChat.
Okay. Okay, Dr. Sano's here. We'll take it one at a time.
Okay. Yeah, so Dr. Sano appears.
Yeah. Hello, Dr. Sano. Can you hear me good, Takashi?
Yeah, I can hear you.
Okay, I can't. Dr. Sano, how are you?
Very good, very good.
Yeah, I'm Dr. Bennett.
Yes, I know.
I know, I met you in Nepal.
So many times.
Yeah. This is, I'd like to introduce you to Takashi Khan. He's a radiation oncologist that is televising this in Japanese.
Oh.
Okay.
Okay, yeah. Thank you, Dr. Sano. I'm Dr. Kong from Showa University, Tokyo. I'm a neurosurgeon.
Oh, I'm sorry. I thought you were a radiation oncologist. I'm sorry.
Yeah, I'm a surgeon. I went to radiation oncology at Duke University.
Oh, you are there.
Sometimes I attend the Shinkawabashi Hospital. I attended your seminar.
Oh, thank you. Video seminar at the time. Yes.
はい。何度かお邪魔させていただきました。
高橋先生、2つ映ってるわ。
2つ映ってます。そうですね。Duplicated.
Yeah.
Okay. これで、あれかな。OK。
そうでした。ちょっとご飯、これちょっとこの全部見えないと。でもカメラこっちなんでしょ？カメラがここで、だからここ、こっち向きが正面に。そうか、そういうことでこれを隠したわけね。そういうことね。これ斜めになっちゃう。これだとでもちょっと斜めだね。こっち見てもこうちょっとこう横顔じゃない。あなたも顔入ってる。ちょっと待ってよ。こっちを見ると、そうか。でも横顔だな。こっち側の方が、こっちを向いてるから、でも、いや。でもこっちのでかいもんね。まあいいか、横でも。そうだね、そうだね。話すときはこっち向いてるんだ。ちょっと。いや、これ、
Hello, Dr. Sano?
No, I have the dinner. So.
Oh, I can hear you better now. Before I could not hear you well.
Yes, okay.
I'm checking with Juha. Okay. And Ben too. Mm-hmm. Okay. Still trying to get hold of you up. We're just gonna sit tight and relax, just like in neurosurgery. So Takashi.
Hey. Yes.
Yeah. So how long have you been doing this, translating?
Translating. I've been about 20 years in the Japanese meeting.
Really? You've done it for 20 years?
And after I trained the translation, simultaneous translation in Japan Neurosurgical Society, and then I've attended a meeting, English to Japanese or Japanese to English translation.
Oh, that's fantastic.
Yeah,
I think we can do something. Definitely.
Yeah,
Definitely.
definitely, yes.
Because yeah, as you know, Japanese have the top neurosurgeons. So it'd be great if the Western society could, could watch their conferences and understand.
Yeah, and connect the Western countries and India and many other countries are very important for Japanese neurosurgeons.
Yes, America. I'm sure they'd like to get connected there.
Yeah.
So this is excellent. This is excellent. I
Thank you.
think Dr. Borber will help that.
Okay. So
because obviously he's very big in neurosurgery.
Yeah, I'll be happy to.
And great. He'll be very happy to hear that.
Yeah, I'll be happy to help and cooperate and participate.
Hey, listen, I'm going to send you a link. It's a WhatsApp link. It's to Louis Borber's group that's putting it together. Okay, and then you can communicate with everybody like me, other speakers.
Yeah.
You know what I mean? It's for the production crew of the conference. Okay?
Okay.
Something is weird. Juha's not answering. Oh boy. Okay. Just hang in there. Today is Tuesday, right?
Tuesday, yes. Tuesday.
Yeah, the banner is right? Did I make a mistake? The banner says Tuesday today.
Tuesday.
It's almost like I made a mistake in the time. Not that I've done that before, but I don't think I did in this case. But let me check.
Okay.
This is very strange. A lot of people haven't showed. Dr. Ben Warlicks. I mean, what's going on?
China 8 o'clock. So China 8 will be 9 p.m. Japan.
Right now, no, it's 7. No,
Seven.
it's 6. It's 6
now
now.
is 8:15 and starting the
8:15.
9.
In China, right?
China is 7:15.
Yeah. We said 7 p.m. So I got the time right. Oh, wait a minute. He said, Juha says it should be 8. Okay. I'm sorry. Okay. No. Okay. Yeah, we're gonna wait till 8. Juha says, sure. Because I'm gonna wait because not only does Juha think it's 8, but Ben obviously thinks it's 8 too. So
Okay.
we better wait till. Okay, can you? I don't know, Takashi, that may hurt you, right?
No, it's okay. It's okay.
Oh,
so
okay.
until 10 p.m. In GST, I'm available. So I will help attend this meeting.
Okay.
Yeah, the practice.
Yeah, so you
translation.
can okay. Okay, folks, I'm sorry about that. We got a little confused about the times or whatever, which is common. So if everyone just hangs on, Yua's on his way home. So he obviously can't do it until he gets home. So Dr. Sano, I'm sorry. Can you wait, Dr. Sano? I hope.
Yeah, I can wait anytime.
Okay, I'm sorry about that. So we should be starting in 45 minutes. If you have some work you got to do. Everybody always has work they can do on the internet.
Yeah,
Oh, man. Oh, Jesus. Yeah, I was wrong. Man, oh, man. I'm wrong. It's 8 p.m. Yeah, I'm wrong. Okay. Hello, Juha.
John. Hello, John.
Yeah, I'm getting a little anxious. Yeah, we're waiting for Ben, right?
Yeah, it is 8 o'clock.
Yeah, so we just have another half hour, right? 30 minutes?
Yeah, I think so. We cannot begin earlier.
No, we wait till Ben comes.
Okay.
Yeah, and I'd like you to meet Dr. Takashi. Dr. Takashi, you there?
Yeah, I'm here. Hello, Dr. Here. I'm Dr. Takashi, come from Tokyo, Japan. I can translate the lecture English into Japanese.
Okay, that's nice. That's very cool.
He's also a neurosurgeon. He's also a neurosurgeon, so that's great.
Yeah, thank you for attending. So I'm interested in I'm specializing in malignant brain tumor, like glioblastoma, and surgery.
Where are you working?
And chemotherapy.
Where are you working?
Yeah, I'm working as a neurosurgeon at Showa University, Tokyo, Japan.
Oh, okay.
Yeah.
Do you know that place, Juha?
Nice to meet you.
I don't know.
Showa University. Private university. The private university in Tokyo, Showa University. SHOWA University, Tokyo.
How many universities you have in Tokyo?
In Tokyo, I think 13.
30. Oh my goodness.
2 national and 13.
Oh, this big number. Yeah, it's a big city.
Yeah, in Japan, all of Japan, 82 universities, medical universities in Japan, and 13 are in Tokyo.
13?
13 or
13? 13. Okay. Yeah, 13.
For about 12 million people in Tokyo area.
Yeah, big city.
They like technology, right? Most of the Japanese people like technology, smartphones.
Smartphones and iPad.
Everybody has well, here too. Everybody has a smartphone.
Oh yes, everyone watching smartphones in the subway or in the train or everywhere using smartphone.
Juha, we have an app now, Neurosurgical TV. So that when you tap it, it goes right into the live webinar. So
okay.
Yeah, check it out. You can download it. Neurosurgical TV. You have to register.
I also downloaded. So
you try it now. Try it now.
I tried. Okay. Yeah. I already downloaded it.
Okay.
However, so using passport.
Let me make sure it's connected and everything.
Okay. But loading appears.
Yeah, it's connected. Okay. Let me make sure there. Yep, it's connected. Let me see mine. Yes. Yeah, if you open the app, it just should come to the main screen. Do you see it, Takashi?
Okay. Yeah.
You see it? Did it come okay? Did it come okay?
Come okay? Yeah. I appeared.
Yeah. See, it came like. See, Juha, this webcast is on the smartphone. All you have to do is touch. You download the app, and then you touch the app, and then the live show comes on.
Okay, so I'm now doing the registration.
Yeah, now you're watching yourself on your smartphone.
Mm-hmm.
Yeah, we got 30 minutes, Juha.
Yeah. 10 minutes. Okay.
No, 30 minutes. Because we have to wait for Ben because he's translating into Chinese.
Okay.
So he's an important part of this, like you are. You're an additional part, a new part.
Mm-hmm.
Oh no, people are gonna love to hear that, man. They can translate their conference into Japanese. You understand it.
That is very important.
It's fantastic. It's so simple. It's not complicated. All it is doing a Zoom on another Zoom. And you can have 100. You could translate this into 100 languages.
Yeah.
You have to organize it, but all you have to do is you come in like you are, and
Oh, yeah.
We could have Swahili.
So here. Okay. Appeared neurosurgical and tap. It's very convenient to use smartphones. You like this? Yeah. Smartphone.
Did you see the lecture? Yeah, you see we're live. We're live.
Yeah.
Now you can just you have the app on the subway, and you just touch the app. It opens right up to the live show.
Oh, okay. Yeah, it's great. So I will inform many residents and many colleagues and many neurosurgeons in Japan and the importance of this neurosurgical TV.
Yes. Yes. We will bring them more neurosurgery.
Oh, yeah. It's a very great and for very informative tool for residents.
Yes. They don't have to participate. They can just watch, and we're trying to make it so that if you like the conference, you can just tap and come into the conference.
Tap and come in,
like a panelist.
Yes.
You may be able to do it now. Like, for example, if you like what they're saying, go, oh, well, I want to comment on that. Boom, you come in. That'll be great.
Only to tap to attend.
Just
connect to
one
word.
Tap to open and one tap to enter.
One tap enter.
Yeah.
Great.
So if that works, I think, and if we get more people to participate while they're on their smartphone, because many people are too busy. They cannot sit at their laptop or desktop.
Laptop, yes.
But they're on the run. They're going to rounds. They're going here, going there. So I think it'll expand the audience.
Expand the audience, yes. It's good. There are several meetings and a very informative meeting all over the world and held. And due to COVID-19, so webinar, Zoom, and very good lectures are easily available.
Yes, of course. I'm so glad. I'm so glad to meet you, man. It's really lucky.
Yeah.
Lucky.
Very lucky. Very lucky.
Very lucky.
Yes,
Let me introduce you to Ben. Ben.
Okay.
Ben, are you there, Dr. Ben? I think. Hello, Giancarlo Perra. How are you tonight?
Giancarlo, hello. How is Palermo?
Are you there, Giancarlo? Your Ben is here, I think. Ben, are you there?
Okay, we are in Sicily, and we have a very good time here. Sunshine, the sea is very quiet.
Yeah, welcome. Oh, there, beautiful.
This is the
This
view from
Sicily. Wow.
it's okay.
Is that vineyards there?
Yeah.
Well, those are olive trees,
Hello,
right?
John. Hello, Professor Juha and
Hey.
Giancarlo.
Hello.
Hi, how are
Hello,
you?
Hi. Hi,
Stephen.
Professor Takashi-kun.
Yeah, thank you. I'm Dr. Kon. Nice to see you, Dr. Ben. You?
Yeah. Yes,
Yeah.
yes.
We're
I
translating
can
this in Japanese too, Dr.
Japanese into
Ben.
Japanese, yes.
Great, great.
Thank you.
Yeah.
Yeah. So to inform the Japanese neurosurgery residents, because your grand round is very informative one.
Yeah.
Great. This is great. This is great. Juha, you're here, right?
I'm here. I'm here.
Well, do you want to wait, Juha, or you want to start? Whatever you want to do.
8 o'clock.
Oh, okay. Okay. No problem. We can wait. Hello, Ben. We have an app now, Neurosurgical TV.
Yeah.
It's a one tap. If you tap the app, you come into the conference live.
Okay, great.
Yeah, if you download it, you have to register like very quick.
Okay,
and
great.
Then, yeah, it's going to make it easy to access this. Because most neurosurgeons use their smartphone.
Can you with the phone? Yeah. Okay. Convenient.
Okay, 20 minutes.
20 minutes.
January 15th, Friday. January 15th is Friday. Yes. Okay. Friday. January 15th is Friday. Yes. Okay. January 15th is Friday. Yes.
Hello, Juha. Hello.
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 Yeah. Speaker. Okay. Hello. Nice to meet you again.
Nice to meet you.
Oh,
Yeah.
yeah.
Nice to meet you.
Hello, 富山先生。
はい、ありがとうございます。
あ、ということで、どうもお世話でございます。ありがとうございます。
ありがとうございます。
Yes.
15 minutes.
For heaven. Yeah, 15 more minutes. Okay. そうか、それかな。こう。
逆のがいいですね。逆のがいいですね。ちょっと待ってください。これここの方がいい。こっち
まあ、窓際の方が電波が。
こっちがこっちで。
ああ、そうだね。うん。その方がいい。そうするとこっち見てやるから。
そうですね。こっち見て。開けた。
みんなで話をするとこっちの方がいい。てててて。ああ、そうか。
これ今これが映ってはないんだよ
ね。ない、まだこれ。
まだです。共有するときに。ここで。共有するの？いや、違います。先生が始まったら。画像、ボブシナルとかして、これを押して。
どっちを共有するか、画面が2つあるから、これとこれがあるんで。
こっちでいい。そしたらそう。
これ横でやってもらえばいいんだけど。
これ、横でやります。横でやります。まだいいです。まだ大丈夫。まだいい。お話を。
そうだね。もう。大丈夫。大丈夫。その方が、まあ、正面見えるから、そうじゃないと、どうしても、そういうこと喋るときは、あと誰入ってるのね。ジョコが。じゃないか。でもあんまりいないな。てんてん。ハロー。富山先生もサウンドオフだね。
ありがとうございます。
こんにちは。元気ですか？
新幹線だから。はい。
今、新幹線、
今日ですね、今日、バンタレで、なんか8件ぐらい。すいません。
本当に。
また報告行きます、川崎に。
はい。はい。Hey, the new bird train.
Yes, new train. Dr. Bing, nice to see you.
はい、みんなね。
そうですか。
そう時計をストップ目の横でいい。
これの音量ここまでしてる。あまり上げてもない。
うん。
Hello, Professor Sano.
Yes.
This morning we have an advertisement and the introduction in the WeChat channel for you. Now the reader is already more than 2,000.
Oh, good, very good.
So a lot. I think there would be a lot of audience tonight.
Yeah, plus the Japanese audience.
Yeah.
We're also televising this in Japanese, Dr. Sano.
Okay.
This is great. Internet is great.
Internet is great.
Yeah. It's turning into television. Really, nobody's going to have televisions anymore.
Yeah.
Good.
But you know, Ben, ideally, you could have as many translators as you have Zoom screens. You know what I mean? You could translate this to 100 languages. Swahili.
Swahili.
Yeah. We gotta find a Swahili neurosurgeon.
Yeah, even translator, there is no surgeon.
あ、こっちに出た。テスト掃除に田中美穂出てた。
Okay, 10 minutes we start.
まあ別にここに今出たらで。ついてきました。開封が。ありがとうございます。いろんな。あとでいいですか。はい、もう大丈夫。はい、あと10分ですけども。緑のチェックが2つついてるんですが、見てるとこなんかラインになるみたい。見てない人は、このグレーの。これ前のやつとかでグレーですけど、で、奥と2つついてるのは、こっちの左側の奥から緑。で、相手が開いたら、こっちの右側が緑。両方にチェックが入ってる。すごい。ああ、そういうことですね。iPhone に入れるんだったら、アップはさっきのアプリを。ああ、そっか、そう。あ、これ。
Everybody waiting on the panel, you can download the app Neurosurgical TV while you're waiting. And you can actually watch it on that. If you tap the app once, it should open up to the live show, which this is now. It's because we're live now, actually, on YouTube Live. Oh, Deepak. All right. I haven't seen him in a while. Let me show you while waiting this webinar we did in India a couple of years ago. Pediatric neurosurgery with Deepak Gupta. 2 days. Let's see here.
They 開始になったら、ここを押して、これを押したら開始になるので、今のとこまだいいです、このままで。
Can't find the darn thing. Hold on, let me keep looking.
動かしてみますか。ですか。
どこにね。
そうですね。こういう感じですね。
こいつね。
そうですね。これで。これですね。はい。
前のエイジェンコングだったよね。
Okay.
みたいな前の時に喋ったの。
Let's see. Is Dr. Gupta there? I thought I saw you coming in. Perhaps not. Pediatric. Dr. Gupta, how you doing, dear? From Indonesia. Danu, how are you?
Very good, Dr. Bennett.
I'm glad you came. I'm glad you came.
Yes, yes. Same way.
Okay, let's see. We start in about, let's see here, 7 minutes. Oh. Okay, 2 minutes.
Please go ahead.
There's 1 minute.
Okay.
Okay. Okay, here we go. Are you ready, Juha?
Yeah, I'm ready. I will give a short introduction and then we give the word to Professor Sano.
Oh, okay, let me just start it, okay? 10, 9, 8, 7, 6, 5, 4, 3. Hold on. 3, 2, 1. Good morning from Miami Beach, Dr. John Bennett for Neurosurgical TV. We have the pleasure of hosting the Juha's China Neurosurgery Grand Rounds. And today, Hirotashi Sano is speaking, and I'll let Juha introduce him and take over. Okay, Juha, welcome.
Dear colleagues, we have the honor to have Professor Hirotoshi Sano now presenting for us. So I share the screen. So Professor Hiroshi Sano is born 1945, but you see he's like a young man, performing extremely well. He's one of the most famous neurosurgeons in Japan, but also in the world. He made his residency in neurosurgery at Keio University, 1971-76. His PhD at the same university, 1978, and became professor, full professor 2000, and professor and chairman of Fujita, 2004. I was in his party for retirement. It was a wonderful party. So a lot of friends and people and also patients are singing. So it was extremely memorable party when he retired, but he didn't retire. He continued to working. He's the famous neurosurgeon called White Jack. I have read his nice memories. I didn't understand totally why he's called White Jack. Maybe he can explain that, but he's famous on that name in Japan. He has operated thousands of aneurysms and still continues international working. He's also involved with Calcutta, with Professor Robin Sengupta in teaching neurosurgery. And we give the word to Professor Hiroshi Sano. He will tell why the clipping is superior to other means of treating cerebral aneurysms. So the word is yours, Professor Sano.
Thank you, Juha, and John Bennett, and now, and I will talk about the two-part. Wait a minute. 共有が。
共有ですか。共有じゃない。
Sorry.
That's okay. Take your time.
Changing the.
ありました。失礼します。じゃあ、はい。
はい。
共有。
There you go. There you go.
So now I am talking about the two parts. This is Juha, and but initially the topic is advantage of the clipping of surgery of the aneurysm. But I will talk about the part one is my history of the clipping surgery. Second part is that one. And first part, I graduated at Keio University 1970. At that time, of course, no CT, no MR, and diagnosis was only angiography. So the aneurysm can easily diagnosed. But others is PG, CG is miserable. With a patient, the convulsion occurred and headache, it's very miserable. But of course, at that time, surgery was macro. And clip was only silver clip, orbicularis clip. Then Scobius and Yasaje's clip and Sugita came. This is my first clip in 1972. You can see orbicularis clip cannot change, not the spring clip. And then Scoville clip and hyphet and Yasaji first generation clip. This is ecomanism. These are macro. I can say that my small microscope. And this is a second generation Yasaji. Here is the ring. So I bought by myself 8 times the handy microscope. This is the one, and I brought many parts to operate. And instrument there was no the bipolar coagulator, only the monopolar coagulator there. Then I made a regular forceps to the fine inside and smooth to ask to touch the beeper and coagulate it. This is maybe macros one sort of skip. And CT was introduced in Japan in 1975, and microsurgery started 1970. This is the first time of the microscope. Of course, no controversy. And then the light was tungsten, then very dark. But that is much better than macro. So diagnosis changed, surgery changed. That was 1975 to 1980. So 1975 first CT was like that. Even this picture takes the one size, it takes 5 minutes. So the whole body, it takes 30 minutes. And we have to tolerate to wait the completed of the taking the picture. And maybe 2 years after picture changed to the like this. But nowadays it's much better. And so the revolution of the new surgery is microscope and CT, of course. And so then surgical techniques got rapidly increasing. And first setup of the microsurgery. And I am using the self-retaining retractor of that, but it must be very flat. This is very important. And put the covering of the this one, and for the fix for the hand, and then stabilize the hand is much better. But many people is putting this self-retaining retractor is very high position. Even this self-retaining retractor, we touched it's okay. But if you put like this way, and the retractor is going to the high and no touch anywhere, we afraid to touch then hand must be like that. So this is not good. Cannot do any good surgery. So the setting up is very important, of course. So, and I made the jet irrigation bipolar system for SH case. This is the jet irrigation. This is the prototype of the jet irrigation, and put like this, and so the irrigated jet irrigation. So it's the irrigate and the subocular hemorrhage. This is very old case because of we are the prototype we are making more than 30 years ago. But we irrigate using the jet irrigation bipolar system to suck out the subocular hemorrhage, like this way, all the way. We irrigate, then change to the the non-ruptured case, not suck the hematoma, but irrigate out. Then brain is very safe. And going to this is internal carotid aneurysm and C23 parapinoid. We are irrigating, and hematoma is irrigating, and Y-shaped superficial vein, if necessary, you can cut. But from the deeper one, it's never. And of course, this is internal carotid, optic nerve, internal carotid. And then how much irrigate? Then we operated and irrigated the subocular hemorrhage. Operated side is not the vasospasm comes, but the opposite side vasospasm comes. And this is 18 gauge needle, and sometimes in the brain, inside of the brain, 23, 21 gauge needle. Needle arachnoid knife, I started. Then that one, here is the aneurysm and the paraclinoid. Then dissect the distal membrane. And here you see, maybe this is a rupture point, SHA, and hematoma. Important point of the acute stage of the subocular hemorrhage is how much irrigate the subocular hemorrhage. That is good for the prevention of the vasospasm later on. Then put a ring clip on it. Then finally, how beautiful it is, even a subocular hemorrhage. This is the point. And after the bipolar coagulation, we can introduce, the dome coagulation is possible. And also, clip should be before because of the, I can say that, non-spring clip. Clip should be finally, but impossible to change. But after the spring clip, we can use the tentative gripping method. This is I introduced. And this is a tentative gripping method. This is, of course, an old case because of I started the tentative gripping more about 40 years ago. And so this is the right side MCA aneurysm. And here is the M1, M2, and the M2, M1. And must be, this is a ruptured point here. Then if we dissect this point, it may rupture. Then we put a tentatively grip on aneurysm involving the M2. Then dissect here. Then it's ruptured, but only the back flow. So we coagulate the aneurysm tip and dissect completely. Then release the tentative grip off and send to the final grip like that one. And pull up the grip, adjust the nicely. So it's the one pattern of the tentative grip. That means if you dissect the aneurysm, it may rupture because of the rupture point here. Then you can forget and put the tentative grip here. And then dissect like that. And then coagulate that. And final grip you can put. That is the point. Another pattern of the tentative gripping method is this is a hematoma of the duct aneurysm, and here you see the aneurysm here. It's very fragile, and rupture point should be inside of here. Then, if we detect, maybe it's ruptured, of course. So we put the tentatively the dome grip on it and remove the hematoma. This is a hematoma, and then this is a rupture point. And then now you can dissect the whole branches, sometimes using scissors, sometimes this is 23 gauge needle. And if you use a needle, you may round part is on the aneurysm side. And scissors, and release the branch, and then you can put the final grip on the point here. If everything was checked, then you may put the final grip here. Maybe it's okay. And means we are putting the dome grip and then dissect and here, and finally this must be dissect and put a grip on here. That means that is another type of the tentative gripping method. And the endoscopy that was also useful. And first was the endoscope holder was not so good, but after the magnetic the stoppers, but now the endoarm is much better. But before we used some cases the endoscope in the opposite side and checking and like that pattern. But the endoscope, we have to look at the like that on a video, not inside of the micro, like this. nicely you can see the back side. And also I made a Sano pure titanium clip, non-blind. That means it's little bit curved and surface, superficial side is the same as the clip holder. And that is good for the prevention of the scissoring. This is a ICPC aneurysm. Maybe this is a S-cup clip or the same type of the here you see scissoring occurred. It's dangerous. Then we release it. And then we use the same side of my clip. Now it's nicely fixed. And also it's a little bit curved here. That is the point. And also this curve can see easily. This is the contralateral approach of the C2 aneurysm. This is a S-cup clip. Cannot see. This is a sweeter clip. The same curved one. And this is my clip. Can see everything nicely. Then even a small branch was preserved and put the clip on. Like that. This is pure titanium, and the endoscope is showing nicely clipped. And this is another case of this is aneurysm of again the contralateral approach. And this is yes, Sano's clip can put like can see nicely. Then it's okay. Nicely clipped. And so recently, maybe 20 years ago, in Japan, the brain checking system was introduced. So there are many incidental aneurysms was found. Then, so the prevention of the rupture and needs much more safe surgery. Generally speaking, they think the single clip is the best because of the starting of the non-spring clip. Then single clip is the best. However, neck of the aneurysm is wide and involves more than half circle of the periphery. So the multi-clipping method is very important, very good. Once I and Professor Yasajiro did the live surgery in Texas at the time, Yasajiro said that you are the master of the march clipper. And so, sorry. It's fixed. Sorry. No, the technician is moving. Okay. Sorry, I stopped the once and it's stuck. Then again, good. どこにいるの？違う風にしちゃったの？ずーっとした。 ここだ。マーチクリップ。これで。Yeah, sorry. Now, back to this is the IC ophthalmic giant aneurysm, but the neck is not so big. If you try to the single clip, maybe it's impossible, but if we put the two clips, first the straight clip, and small remnant, it will be clipped. That is the pattern of the march clipping. Scheduled march clipping means we have to think about the final situation. Then first clip should be thinking of the next clip. Then many people put the clip on and there is some remnant, then put the clip on. That is not the march clipping method. We are putting the first clip and then thinking about the final situation. And preservation of the perforators. Don't want to. It's not moved. Yeah, sorry. Oh. Okay, skip the video, but that case was the very advanced of the antecoital artery. Many people is putting like that, but we put the link clip first, and then put the second clip. Then we can preserve the perforators. And branch and perforator again. Sorry, computer is not.
That's okay. Take your time.
Okay, thank you.
You all can relate to tech issues. That one is going back to you. If every case was like that, it's simple, but some cases very effect of the perforating artery on the at the time you can use the link clip first, and then second is the combination of the next march clipping method. This is much easier. This I show, and again this is here is the perforator here, and branches a little bit difficult to. Then we jump using the link clip. However, clip itself is a little bit too wide, and here is a small kink here. You can see. Then other times you can
release the clip, and then you can drill using diamond drill and make it narrow. Even titanium clip, you can cave it and put the clip. So it's nicely preserved. And another clip, another one is easy to put the clip on, like that. And so penetrative clip is very useful. And this is one, and MCA aneurysm branch is attached on the aneurysm head. Yeah, of course you can dissect over this branch completely, but neck is here. At that time, you can use a ring clip to try to but this is the thin walled part. Then neck is here. Then you can jump off that branch and put a clip on. And this point is a usual clip is too long. Then you can cave the clip itself to put it on. And here is a small remnant also you may cave. So sometimes you can cave the clip, and that is no problem, and do it like that. So the preservation of perforator and branch is more important than occlusion of the aneurysm itself. Giant aneurysm. This is one of the giant aneurysm, but this patient is a little bit old, almost going to 80. Then I don't like to do the surgery. Then we are observing, and this is the aneurysm, 4 centimeter in diameter. And but patient came subarachnoid hemorrhage, but grade 1. Then I operate on Sunday. And then the C3 portion was open. And this is the C3 and C3 portion. Nowadays, maybe suction decompression is much better. But on Sunday, intervention doctor did not come. So we just open the C3 portion and dissect the aneurysm. This is optic nerve. And this is a ruptured aneurysm. This is probably the ruptured point when we detect here, and it bled. So stop it anymore. But then we put a clip on like here. And but this is ruptured aneurysm, so the wall is very thin. And this side more. And this clip is not widely open, so this is my fault. Then I am watching this side. Then I stick the aneurysm. It's very bad. So and a big suction, maybe Dr. Yokato is sucked the blood, and at the time I detect more. And detect this side more and make it soft. We have to change this clip. Then open a clip. And you have to remember the ruptured point and little bit the arterial side to fix it, and this side putting on. This is important. You have to make the hand remembering of the position of the clip. And another one, maybe blood is coming from the backflow from there. Then it stopped. But it's a little bit anxious. Then we put another clip on. Yeah. And release the temporary clip off. But if we stick here, still it's bleeding. So it is not good. Then we put a temporary clip again. Maybe outer side, lateral side, there is a hole. Then clip should be changed to the inner side more. So this position is a little bit the arterial side. Then, but this aneurysm, this aneurysm of the wall is a very thick the inner part. Then turn to the hand to the inner way. And this blue one, the next one is also this lateral side is the same position or a little bit arterial side, but the clip itself was the turn to this side. Then artery became a little bigger, and hole is out of the clip. And check the endoscope. And for safety, aneurysm ruptured this time. And for safety, we put another one more clip. And also check that one more clip for safety. And the endoscope is showing nicely. This is the endoscope. And this is the temporary clip off. So nicely reconstructed. And endoscopy showing here is the hole and fixed of the artery itself. Patient is completely well. This is the endoscopy. Fixed hole is here. Hole is here. And very old 3D CT angio showing good. MCA, thrombus giant, thrombectomy, and it's a thoracic hemorrhage. And here is the intraoperative angiography showing the giant aneurysm, partially thrombosed, like that. Of course, this one, we have to trap and open and remove the thrombus. And then for trap, this is M1. Probably this is cutoff surgery, and I am assisting here. This is my hand, and this is cutoff's hand. And put the temporary tape on, and whole branches, and opening the aneurysm and remove the tombs and trim the aneurysm. This is my hand, and this is my hand, and then orifice is from here to here to reconstruct. And other time you have to use the ring clip. Otherwise, maybe it's not strong. Ring clip is much more strong, and because of the thick walled aneurysm. Maybe I think this side is better, but anyway, and also open the temporal clip off once, and the air and thrombus should be out. This is important, and then obliterate the completely. More 2 clips. Maybe this point is much better. But anyway, then Doppler shows okay, and the endoscopy shows there is a temporal clip off, and angiography nicely. And partial thrombosed giant aneurysm, thrombectomy, and temporal clip, of course, and then reconstruction of the artery, sometimes using the bypass. And I also made the bone punch, anterior cranial process. This kind of the surgery nowadays is IVR. This is very old, 1985 or so. Then C3 portion. Remove the anterior cranial process completely, and the distal dura was cut. Distal ring, I mean. And this is optic nerve, and then can move where so we can put a clip on, not so difficult. This is a bingo doents way. We learned bingo doents, but I made the anterior cranial punch, and I gave to Binko once. He was good, and the endoscopy showing like that. Then nicely clipped. And nowadays we don't do anymore, but before Binko Doents made the conference at the time, I was showing this case, bilateral giant intracavernous aneurysm. So at that time, no IVR. Then we open the neck and open the craniotomy and remove the anterior cranial process and dissect. This is the cavernous sinus, and then optic nerve, internal carotid. Then put a temporal clip on neck and opening of the aneurysm itself, going to inside of the aneurysm, and then check the orifice. Orifice is not so long, and then on we dissect the the aneurysm wall like this. Then this is the inside of orifice to here, to here to here. Then we have to reconstruct here to here. So then dissect that, and so the we ask to the assistant to hold here. Then we reconstruct from here to here. Then twist and ask to him hold this wall here like that. And then twist, and this is the assistant and button. Smooth. Sorry, go back to. I put I clicked it, so it stopped. Sorry. Again. Sorry. Inside of the aneurysm, and then check the check inside of the aneurysm and dissect the aneurysm. That was 1985 or so. Maybe before being doing first the cavernous sinus conference, I show at the time of this case. Then like that, and throw it out, up, and then flash your back, and then take it, and also back flow. Then no air, no thrombus, and obliterate here. And again, remove the temporary clip off. Of course, distal first. Then ask to the neck part. Now it's pulsating nicely. Like this. And close the door. And post-operative. This is a clip. This portion. very nicely reconstructed. But nowadays, we don't do it. Maybe pipeline is much better. And Fujiform arguments most of the time. Usually the dissecting, the trapping but they said the clipping is impossible, but we did. VA dissecting aneurysm. This is giant, but it looks like here, but if we take the 3D CT angio, it was thrombus. Then thrombus means the dissecting aneurysm, and inner wall, the thrombus was inside of the artery. And this is the distal part, proximal part, and put the temporary clip on the distal part, and endoscopic showing this is this. And here you see this is intramural thrombus, but in the arterial part, it's here you see inside of the wall hematoma there, but here, but only the neck itself was intact. Then we decide to reconstruct the artery. Here you see this is dissecting aneurysm, but neck itself was safe. Then put the clip on, another clip on. Like that. And this is a temporary clip off. Doppler shows good. There was no ICG at the time. And the endoscope showing good. But the wall itself is not beautiful. Very unusual. But then this is post-operative patient is good. And another weird dissecting aneurysm. Another Fujiform, I mean. This is Fujiform aneurysm. And pica is coming here. That means this is a normal vessel. Then opposite side is that, and this is medulla oblongata. And beside of the medulla, we are putting a clip on. Anyway, we are putting a temporary clip on the VA proximal portion and using ring clip distal part. Distal part. And then proximal second. Here. And then maybe a little bit more. And there is a space, so we need another clip. And doctor showing, and patient is okay. And more than 20, 30 years, the patient is still the same size of the artery. Butler aneurysm, Butler giant. I don't like to do the surgery. Then I said to the patient, maybe I operate and 50% will be die and 90% will be complication. But the patient said, oh, then I will have a surgery because another 5 doctors, all doctors, they said 100% die. So I have to do the surgery. And then checking that vein, and then for vein is going to the lab. Then cerebrum vein was cut. That vein is going to lab. Then no problem about that. And third nerve and bladder aneurysm. Some small antecoital artery. Then put the clip on. And this is a CA, and to reconstruct. But this is a bladder SCA and the lateral anterior position. That is the reason I tried. Otherwise, I don't like to do it. Then release the temple, and then and check the endoscope is okay. Yeah. But nowadays, maybe IVR doctor or pipeline, but even though small antecoital is very easy. And intraoperative rupture is very problem. This is a case of the maybe 2004 in India, live surgery, and this is only the bladder artery. And then moyamoya disease, both sides of the internal carotid are obliterated. So I don't have to do that. But they said, you can do it, otherwise patient will be died. Then I have to do it. And before the surgery, I made like this. And PCOM should be very, very big. And so, and this is PCOM, very big. And bladder here, and aneurysm. This looks fragile because of this patient had a subarachnoid hemorrhage 20 days before. Then this is aneurysm, looks very fragile, and aneurysm and PCOM and bladder and PCA. So at the time I try to put a clip on, but looks here it looks very fragile, so but it's ruptured. At the time, you have to, of course, you have to put a temporary clip on bladder artery and check around here, and it's still bleeding. That means probably ophthalmic artery will be, it comes from the backflow. Then we can take a time, maybe 10 minutes or so. Then we put one more clip to push here, insert here, and without this clip, this is a guideline clip. Then release this clip out. Then afterward, we can put the clip from the parallel to here, this little bit proximal position. Then defect here. At that time, important point is you have to make the hand remembering the position. And then hand should be going to the same position to put the clip on. Just parallel, just about proximal. Then release the temporary clip off, it stopped, and it's nicely finished. And about the temporary clip 10 minutes, and so it's okay. And the patient go back 2 weeks afterward. And that was done in only 20 only 24 hours. And at the time of conference, surgery, and welcome party, and going back to the airport within that 24 hours, only one day. And this one is also very some strange aneurysm. And then, but here you see many perforators, just a little bit mid-bilaterality or upper part. Then only the way is you have to use a ring clip small ring clip to skip the perforators between clips under the temporary clip on. First clip, ring clip, and here is the perforator, then second ring clip, preserve the perforators. But nowadays, that time there was no IVR. Nowadays, I would like to ask to IVR doctor. Then all the branches was preserved by between the clips. So this is the final clip. Between the clips, branch was coming. Here you see like that. Then temporary clip off and check the endoscope showing like this. All branches is preserved by ring clips. This is only the way to preserve the perforating artery. Now going to the next topic, but we'll skip very quickly. Advantage of the second part. And original artery reconstruction. This is the first case of the original artery reconstruction. That time, this is MCA aneurysm. And if we put the clip parallel, it's cannot impossible. But if perpendicularly, here is the ring, we put another clip on, so we can make the originally artery reconstructed. Then that is the surgery. It's impossible by the endoscope, but the original artery reconstruction is a big advantage of the surgery. Dome coagulation. Coagulation of the change of the aneurysm shape to easy clippable shape by dome coagulation. That is outside approach, then we can do it. For example, this kind of aneurysm and big shape, and this is an operative view with a vein. And before the surgery, we are always drawing the picture, maybe skip, and then we coagulate of the aneurysm to easy to clippable shape of the aneurysm, and then put the first clip here and concentrate of only this point, second clip like this, and under the temporary clip 4 times. Then post-operatively, very nicely reconstructed. Nicely reconstructed here. And sometimes fix the grip of the aneurysm and move to adjust the grip itself. This one we put a clip on, but this point is a little bit, yeah, maybe okay. ACOM aneurysm. This is not so. Many people just adjust the grip on the aneurysm, but sometimes you can fix the grip, but through the aneurysm itself to inside of the grip. Then it's nicely. And here is the ECOM. Check the back side, of course. Balance grip and this position, but the grip cannot move anymore backside. Then fix the grip itself and pull the this point to inside the aneurysm here like this. Then pull it and then close the grip. Pull, then close. So it's nicely. Just the sides. And this is a temporary grip off. Usually they apply the grip to the aneurysm, but sometimes fix the grip and then apply the aneurysm into the grip. Difficult case for IVR. This is penetrated ECOM. Penetrated ECOM. You see upper and lower, back side and forward side. Then we can use the ring grip and here is the aneurysm and backside also. Then prepare this ring and put the temporary grip on both sides and coagulate of the aneurysm. And this is hypothermic artery, must be away from the neck. Here you see hypothermic artery. And then put this is under the third cell hypothermic artery and put the clip on. Then this is the temporary clip off nicely. And like that. And then post-operative angiography showing ring was there, aneurysm was gone. This is the aneurysm clip, only ring was there. And then March clipping, you must image the final pattern, then put the first clip and deeper one first and a shallow one next. And at that time, you have to concentrate on the tip of the blade. Less part will be obliterated by second blade. For example, this is the 80 something years old woman, but one aneurysm here. But this aneurysm looks very fragile. Then, but the artery coming from the aneurysm wall. So, and see that. Then this part is probably very thin wall, but the artery is coming. Then we scheduled maybe this part we can remain, and but put a ring clip of here and obliterate of here. Then half of the aneurysm rupture, easy rupture point will be obliterate. Then this is fragile part, and then we can put a ring clip involving, and this is the branch. Putting the ring clip, and under part it's not so fragile, so the put the clip on, and then another clip on here. So then the fragile part was obliterated. But ICG shows, but when we touch a little bit ruptured, maybe small part was blood is coming, then we obliterated the upper part also. Then it's okay. Now, good. We did, this branch must be preserved, so that there must be the small remnant, but it was scheduled like this. This obliterated this line, then using this one and this one, and the upper part, like that. And post-operatively, nicely reconstructed, and branch was remained. Branch was remained, and this is a remnant part. Branch is here. The growth of the aneurysm recently, IVR is much more often de novo. And for this case, MCA aneurysm, first clip we did, maybe skip, and like this. And it was post-operatively, it's narrow, but 3 years, next year, it became nicely, then nice. 3 years afterwards, nice. And 4 years afterwards, maybe growth in the remnant. And 5 years afterwards, it regrowth. Now 6 years, then we try to do the surgery, and then like this. So this branch was only this branch is not waited. If only we can preserve this one. This is by bypass. See, this will remain by clip, but this branch may be by bypass, like this. So put the clip on branch here, and obliterate here, and put the clip and bypass, and maybe skip. And so we did. Nicely reconstructed. Nicely. And same one is this patient coming. Maybe IVR is impossible. So this one is first we put the plan STMCA and OBJ here. And first then a bypass, and then we obliterate all the this gland and by bypass and only this way. You know, and postoperatively nicely. And this large giant aneurysm maybe can put a clip, and but afterward we use Nobel sheet. What is that? Someone and then the postoperatively, but 8 years afterwards, the same position. We are using the Nobel sheet. Maybe collagen fiber is the growth, that, and then the enforcement. And lapping can possible because the surgery is outside of the, and that is the Nobel sheet. This is a Nobel sheet. And if we use a glue, maybe it's made very, very strong. But 3 months afterward, it will be absorbed. But there is the collagen fiber is introduced like this. And if also another useful way is the instant lapping clip you can use like this. And then so this is after 3 months afterward, it was the collagen fiber introduced. Here is this is a defect part area, but the collagen fiber is coming. And lap clip also, and blister maybe to skip. Critical aneurysm. Maybe this kind of shape of change. That these are fit for aneurysm. We are trying to surgery, but difficult to IVR. But we are dissecting and then put a clip on. And 1, 2, and also afterward we lapped completely of that maybe 3. And using the Nobel sheet, we lapped completely and enforcement. Like this, ICG showing very nice. And this is a Nobel sheet, fixed completely, like that. And post-operatively nice. And another one is almost the same, and we put a Nobel sheet first and lap it on the clipping on lapping method. Like that. And giant fridge form. This is one of the giant aneurysm backside. Maybe you can use a ring clip to reconstruct the artery. And here you see this is the aneurysm and the penetration, and you can reconstruct the artery here. Maybe it will be stiff. Like this one, we can put a clip, and then between this is hypothalamic artery to reconstruct and preserve. postoperatively very nicely reconstructed. And another common, here you see almost the same pattern, but reconstruct using the link clip like this way. Maybe it will be skipped. Postoperatively very nice reconstruction. And perforator is very important. And this is partially thrombosed giant aneurysm. Put a clip on, but it will be skipped. Sometimes we are putting the clip 1 and 2, and between the two, here is the SHA, and here is the anterocoidal artery. And then that means, sometimes I'm saying, if the end of the vessel, will be a remnant. But between the two, this caliber cannot will be obliterated. But if there is on a small vessel there, only the vessel can preserve. This is a small trick. And this is another case of the ruptured anterocoidal artery aneurysm. Anterocoidal artery is coming from the aneurysm itself. It will be skipped. And here you see anterocoidal artery is coming from the aneurysm itself. Then we reconstruct the artery and preserve the anterocoidal artery. Then patient is completely well. And maybe almost 5 centimeter diameter giant aneurysm, IC bifurcation, and MCA, A1, IC. And maybe we do the bypass and then to reconstruct reconstruct it like this way. That is only the way to preserve the perforator. In case of the perforator arising from the aneurysm wall, possibly by only by surgery possible. And this is the last case of the India in province in Calcutta. And this is a subarachnoid hemorrhage case. Patient comes, and before the surgery, I'm always drawing the picture and explaining to the audience. And Dr. Komatsu is assist me of the neck open and suction decompression method. And now, I have to show on last of this case. And this is the left side internal carotid, optic nerve, and dura open, and aneurysm here. But it looks very fragile artery. And then I have to do the obliterate of the neck and suction decompression done nicely shrink. Then we put the clip to the here, but here is a very fragile. We are saying, oh, this is very fragile. I don't like this wall. Then to reconstruct the artery and to put the another link clip. Now it's reconstructed. Then we have to open the neck, but this is very fragile artery. Look at here, it's red. Then we have to obliterate. Maybe thinking that the trap and bypass, but if so, maybe it takes a long time and not good. So at the times, the rupture point is not so big. We are putting a nail bell sheet under the clip and on the rupture point, and insert, and with nerve sheet enforce the rupture point, and put the clip on like this. This is a little bit narrow. Then we are putting a little bit more big, and another nail bed sheet and most of the nail bed sheet, and put it on, and also straight clip. Then this is the temporary clip off, and asking the opening, then nicely reconstructed. And ICT shows well, and like that. Then put a clip like that. Maybe suction decompression 8 minutes, 10 to the 15 minutes because of rupture, and then second time is 8 minutes. So advantage of the surgery and original artery reconstruction we can do, and dome coagulation to change the shape of the operable, and reduce the current by lapping because of the outside of the approach. And surgery is the outside approach. Then attach the intima by clip, and change the shape of the aneurysm by dome coagulation, and also enforcement by lapping. And not clipping versus IVR, but maybe which is the best? Maybe clip or IVR, or just some cases approach. And easy for approaching is clipping better, but the difficult for approach itself is IVR better. Preoperative image is the first stage. Actual surgery will be the second one. Then we are doing the surgery, directly surgery is the second time surgery. Then always no mistake. For skill of the surgery, I'm always saying, image of the preoperative view before the surgery is the most important. But 60% by imaging eye and 40% by actual eye. Move hand freely and become in nothingness during the surgery. So, and then I am making the Sano-Sengupta Academy on aneurysm surgery in 2018, but now Corona, now it stopped. But this is Robin Sengupta, and we are doing it together. And the operation is not a circus. Operation is like a walking on the bouncing from low position to high. Then doing difficult thing in a difficult way is average, but doing the easy thing in the difficult way is poor. So doing the difficult thing in an easy way is a master. So then you are training, you will be a master. Thank you for your attention. Thank you.
Thank you very much. Juha, you want to lead the discussion? You want to start off the discussion?
Yeah, sure.
Yes. Okay. Thank you very much for wonderful lecture. We saw 50 years of clipping. So
yeah, 50 years.
His experience. My presentation is here. I don't know. I have to close it. Sorry. Okay, 50 years of clipping. So this was wonderful experience. So we should see how the neurosurgery has developed until today, and Professor Sano is still continuing to do extremely difficult cases. So what I saw in the intraoperative picture, it was extremely well documented. I didn't see a lot of atherosclerosis in these cases. How it is in Japan?
Maybe Japanese is thick.
Average age is extremely high, but you don't seem to have a lot of atherosclerosis. In China, it is the extremely big problem for open surgery, besides the attitude that the people are extremely afraid of opening the head. So this is how the culture is here. So in Henan Provincial People's Hospital, there are maybe 1,300 aneurysms, 1,000 have endovascular surgery, and 300 are clipped. This is something, the clipping, one of the difficulties is the extremely frequent heavy atherosclerosis, at least in Henan people. So this is one of the big difficulties. I think maybe Subin can comment on that. But first I want to hear, how is it with in the older people? You are operating on 80 years old, 90 years old. You have atherosclerosis in these cases.
Yeah, atherosclerosis is very problem, but at the time we are imaging the inside of the caliber, and then maybe a little bit away from the dome part, and if the aneurysm partially sclerotic and partially venous involved, maybe two clips as sclerotic part was away from the artery itself, and but the non-artery sclerotic part is very close to the artery. So we are imaging all the way inside of the caliber. The inner caliber is much more important, I said. Yeah, and in Japanese and it's skinny. So, but recently much more sclerotic patient comes. Yes, same as European.
Okay. Dr. Sen, I'd like to introduce you to Warlix. She's the usual moderator. Hello, Warlix. I'll let you lead the rest of the moderation. This is Dr. Sano. This is Warlix, yes. A Thai neurosurgeon.
Yeah.
Hi. Okay. Greeting from Thailand. Dr. Sano. My name is Walalat. I am a neurosurgeon from Thailand. Now I practice on neurovascular and also endovascular.
Yeah, yeah, you can use the both technique.
Nowadays, yeah. Hybrid. I go and visit Professor Dr. Shinimura in Hyogo. So I practice with him. Yeah, and I plan to go and practice more after COVID. Thank you for your amazing lectures, and I really love your illustrations and your planning, in which I used to read your books, and I still do it. I mean, illustrate the aneurysm picture before I do operations too. But it's not as beautiful as yours, though.
But you are still young, so you have many cases more.
No. Okay, so okay, it's time for the floors. If anyone have a question or any comments to ask Dr. Sano, please feel free to ask the questions directly from the book. Actually, I have questions from the panelists in which HKG.
There's one question in the panel there in the chat, if you want.
He asks about how long is your temporary clipping time, I mean, in which that you consider is safe, like the durations that you usually do the temporary clipping.
Of course, the 5 minutes is always safe, but the non-sclerotic part you have to select, and 10 minutes probably safe, but more than 15 is you have to make that hypothermia, or of course you have to monitor or something, but you have to more than 15 minutes you have to do the hypothermia or something. Maybe you have to release once more than 10 or 15. Yeah, less than 10 minutes is always usually safe, but less than 5 minutes, no problem. Juha? You have almost you have the same opinion.
I agree totally. I agree totally. 5 minutes always safe.
Hello, Dr. Sano.
Yeah.
Hey, Victor.
Hello. This
Hello,
is Dr. Victor Hugo from Mexico City. Your lecture was really amazing. Congratulations and happy Christmas in some days.
Thank you. Thank you.
Warlix, there's a question in the chat. Harshad, you want to ask the question directly? You're muted, Harshad.
So Dr. Harsha, he asked about, do you have an experience doing those surgeries in the grade 4 or 5 suboperational hemorrhage? Yes.
Did you get that question? You get it, Dr. Sano? Did you hear the question?
No, no. Is that to me?
Yes. Do you advise, go ahead, Warlix.
Do you advise surgeries in grade 4 or 5 suboperational hemorrhage in rupture?
Yeah. Yeah. Of course, you have to put a temporary clip on first. If it's ruptured, then you have to dissect the proximal control usually. And if it's ruptured, of course, put a temporary clip on. And then if still there, maybe you may trap the aneurysm. Then aneurysm is no bleeding, just the wall. Then you have to think about how can you do it. But many people became panic. That is very bad. Maybe you may take a deep breath first and put a temporary clip on, and then think about it. 5 minutes. You have 5 minutes. 5 minutes is very long. So don't worry about that. That is my comment. Be calm always, even after, but put a temporary clip on and reduce the breathing, and then dissect the neck part, and then if necessary, that you have made the dome clip and obliterate it, and open the temporary clip off, and then dissect more, and then you can put the final clip. So, but if you became a panic, it's a very miserable.
Actually, the question was if you are operating on high grade 4 and 5 patients.
I mean, you mean the grade, maybe if the pupil was one side dilated, that one we are doing. If a patient has a hematoma or the hydrocephalus, that one we are trying. But it was completely coma, and then without hematoma or hydrocephalus, and that was the brain swelling. No operation we don't. We don't try to anymore.
Right.
It's impossible. That patient is almost dying, so that we cannot put it back to the dying patient to the life. Yes, is that okay? Answer?
Yeah, okay, Professor. This excellent lecture. And I agree, we follow the same principle. And I ask every presenter about this, about grade 4 and grade 5 subarachnoid hemorrhage. We see very many times, and it becomes a dilemma what to offer to the patient. So, this is what we understand. The results are bad in grade 4 and 5 to operate on those patients.
Grade 5 patient is very, maybe only 30% survive, and maybe 10% can be back to the social life. But the grade 4 is there are many cases to getting back to the usual life. But grade 5 is very difficult. But maybe 3, 4 glaucoma scale, 3 is never. 4 is difficult. Maybe 5, 6 could be.
Do you advise endovascular treatment for grade 5 aneurysms? Subarachnoid hemorrhage.
If if maybe grade 5 and pupil dilated both sides is impossible. But the half size only the hydrocephalus, maybe it's possible. Yeah, and but if the hematoma there is the surgery is better because we can remove the hematoma at the time.
Right. Okay. Thank you, Professor. Excellent talk. Excellent presentation. Thank you.
There's a question on the panel, Borlix. Do you see it?
Okay. So Dr. Jose, he asked questions. Are you doing routine intraoperative neurophysical monitoring?
Yes. MEP usually, and paraclinoid is the VP, and yeah, that's it. And maybe that's it. Usually the MEP.
With MEP.
Always.
Where's Warlix? We're supposed to fill in these gaps. Are you there, Warlix?
Yeah, I still waiting for more questions.
Oh, okay. Well, you can harangue and harass people to ask questions. Let's see here. Does anyone else have any questions?
Yes,
Go ahead.
one more.
Go ahead.
Professor, do you encounter post-operative vasospasms in your patients?
Yeah, but recently I don't do the subarachnoid hemorrhage, but before. Usually surgical side is not the vasospasm not come, but the contralateral side vasospasm come because of the not touch the brain, but just irrigate and wash out of the subarachnoid hemorrhage. But the contralateral side we cannot remove the hematoma. Subarachnoid hemorrhage. Then the contralateral side subarachnoid hemorrhage comes usually.
Do you use nimodipine?
No.
No.
In Japan, not so popular.
Not popular.
No, Eril we can use.
Do you use papaverine during surgery?
Sometimes yes, but yeah, we are using the Japan is using the Eril.
Right. Thank you, Professor. Thank you. Wonderful.
Do you see that question, Warlix?
Yeah,
there's two questions actually. So take your pick.
Okay, so more questions from Dr. Amy Singh. He asked, do you open laminar temporalis to avoid post-operative hydrocephalus?
Yeah, and echomanism, yes. And if there is a hydrocephalus, and the echomanism laminar terminalis will be open, and then so the hydrocephalus. And but the bad grade patient, we cannot go to the laminar terminalis without the damage of the brain. So the time we tapping of the ventricle and reduce the brain, suck the brain, then approaching. Otherwise, maybe we damage the brain.
Okay. Next question from HKG. He asked, do you recommend intraoperative DSA or ICG or that
Of
is
course.
enough in complex aneurysms?
Of course, all the cases we are doing the ICG and just the checking the flow, and of course that is a routine now. But showing the old cases, I show the many cases, very old one, maybe 20, 30 years, 40 years back. Then no ICG, maybe 3D CT angio was very poor at the time. But that is the reason I spoken about my history of the aneurysm surgery, from the Olive Corona to Scoville, and macro to micro, and handy micro to the nice micro, not contrabass, and then contrabass, and pentero, and Leica now. So that is my history. Nowadays, of course, monitor, the ICG, all everything we are using, of course.
Yeah.
Do you see that last question? Go ahead. Go ahead.
Thank you for the opportunity. Hello, Professor Sano.
Hello.
It's been a great pleasure to see you again. We met in the last winter seminar in Nagoya, and I had the privilege to taste the matcha from your own. You made matcha yourself. It was a privilege. Also, it's a good taste. And Professor Kato always said that you already did the aneurysm clipping in your imagination. Your imagination is so strong. So when you open the surgery, you just did the second surgery. Amazing.
Yes.
By the way, it was a great pearls of knowledge you gave tonight. My questions is very basic, so would you please bear with me? In case of the ACOM aneurysm projecting inferiorly, so in a way that it was too big and we cannot see the contralateral A1, is it okay to skip the part of temporarily clip the A1 contralateral and straightly clip the aneurysm itself? Thank you, Professor.
At the time, even aneurysm is downward, but which A1 is dominantly into the aneurysm, then that side you have to approach. Other side, if you approach, maybe but the dominant side of the A1, even the same size, but the flow itself, if you are thinking about this right side flow is going to aneurysm directly, or left side flow is directly. Which side is going to the directly before the surgery, you have to decide. Then that side, if you approach, then putting a temporary clip is easy. So then imagination surgery is very important, I said.
Thank you, Professor.
Okay, Warlix, there's a couple of questions in the chat. You want to read them, Warlix? Another one from Joseph Dudu.
Okay. He asked, do you advise surgery in the rupture aneurysm that presenting in the day 4 or 5 with angiograms showing vasospasm? You going to advise for surgery immediately or to wait?
No, that time, if you find 4 or 5 days after the subarachnoid hemorrhage, maybe IVR is better. And maybe after 2 weeks, it's okay. And or within 24 hours, maybe we, at least 72 hours, 3 days, maybe 1 or 2 days afterward will be okay. But 4 days, 5 days, 10 days is very difficult to do the surgery because the vasospasm occurs later on. So the IVR is much better. And at the time, IVR to angioplasty can do it also. So that maybe if there is a vasospasm, maybe we don't like to touch. Okay.
Okay. Warlix, anything else? Do you see any more questions, Warlix, in the chat box? I don't see any new ones. Do you?
Yes, I have a question from Dr. Rubes, but I think that Dr. Asano answered it already. He asked about like sometimes that maybe temporarily clipping is need more than 5 minutes for do temporary clippings. Do you change the place for temporary clips in different times?
Yeah, more than 5 minutes, maybe 10 minutes. Yeah, we are, but more than 10 minutes, maybe this is a temporary clip off, and then before that you may put a dome clip or something, and then holding the rupture point, and then release a temporary clip off, and to brain circulation is going to back. And then maybe 1-2 minutes afterwards, you can put the temporary clip on again, even the same position. Or you can do the hypothermia 30, if the 34, maybe 15 minutes will be okay. 15 minutes. And then 32, maybe 20 minutes will be okay.
Okay, see any more questions there, Warlix?
No.
No, okay. Okay, very good, Dr. Sano. Thank you very much. I'd like to thank you for a great presentation, and I'd like to thank Ben. Ben, can you say hello, Ben, for translating into Chinese? Translate. Say hello.
Yeah,
there's Ben. There's Ben. He's a neurosurgeon from Shanghai on TOPS, and he translates to hopefully a good audience of Chinese neurosurgeons, and we really appreciate
Sean, tonight there's more than 3,000 audience.
Oh, great, great,
great,
3,000.
Great, and thanks Juha for bringing Dr. Sano to the Chinese neurosurgery population. Okay, Juha, any plans for future episodes or?
Now we make a break for Christmas and New Year. I wish all happy Christmas and New Year, and then in January, Vinko Dolens has promised to speak about cavernous sinus tumor surgery, January 15th. This is the first in our program.
Very good. Thank you very much, everyone, especially Dr. Sano. Thank you.
Okay.
Thank you.
Happy birthday. Happy Merry Christmas and
Happy New Year.
Thank you, Professor.
Happy New Year.
Happy New Year.
Thank you very much.
Have a happy New Year.
Happy New Year. Thank you.
Bye.
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 Bye. Bye.
Well, okay.
Bye, Professor Juha. Bye.
Thank you. Thank you very much.
最后大家
拜
圣诞和新年快乐。好，
Who's that?
也感谢今天大家参与。
That's great. Into Chinese and Japanese. You know, hey, Victor.
Hello, John. Hello, John.
Very nice. Yeah, Victor. Thank you for the blurbs that you're putting up there. Those creative editing, putting pictures. Victor, during the presentation, Victor puts up posts of the lectures and explain. It says a remark. What's going on? That's great. That's great. So, Ben, are you still there? You're gone. Okay. Okay, yeah, Victor, in Japanese and Chinese.
Yes, was great. Was amazing.
Yeah, Dr. Sano, we'll be able to televise you in Japanese too.
Yeah, yes, I know that there were also 3,000.
You are driving. You are driving.
Amazing.
Yeah, yeah, Victor's driving, but well, you can get arrested. My brother got a ticket for that in Hawaii, $300, because he was talking on the iPhone driving.
No, but this is hand-free.
Oh yeah. That's okay. That's okay. Yeah.
This is in hands-free.
Oh, good. Very advanced.
The Warlocks, are you there?
Yes.
Warlocks, are you thinking of going to Japan for a fellowship in vascular?
Oh yeah. I will go to stay with Professor Shinichi Yoshimura after the COVID's like more stable. Like
Big
maybe
stay.
1 year from now.
Okay,
Good.
Well,
yeah, but I read all your books, Dr. Sano, and I really like your. Sometimes I still like sketch from your. The most difficult part is drawing
we are welcome.
Drawing the clip. It's really difficult. You have like a lot of choice of clip, like fenestrations or type things, like to do the closer lie. So it's like a newbie like me. It's still challenge to choose the right clip for aneurysm. Today I did the rupture A aneurysms too, and here we go. I have premature rupture again. Still practice on that.
Okay.
Hope you
very good. Dr. Sano, download the app. We have an app now. So download the Neurosurgical TV. I'll put it in the chat, Neurosurgical TV. And so when you tap it, you'll go right into the webinar with one tap. So, when you're on, I know in Japan they're strict about the subways. You got to be quiet. But you can watch a neurosurgical webinar like we just had. You can watch that on the subway.
Okay.
So very good. So how's the book? How's the book? Do you revise it, or is it going okay? The book, The White Fox, the book. Are you still revising it or adding to it, or?
White Jack. White Jack.
Yeah.
Yeah, we have. Yeah.
It's still available, right, on Amazon?
Yeah, still available. And
on Amazon, right?
But yeah, you have to ask me directly because of I can give you.
Oh, no, you gave it to me in Nepal. I still have it. Okay, let me. What's it called? White Fox, right? White
Jack, because of the Black Jack in Japan, and that's a comic. Is he is the non-licensed surgeon, but he operates everything nicely. But I have a license. Then I am a White Jack. Maybe legend makes my name white. He said, you look like a Black Jack. Then no, I have a license. Oh, then you are the White Jack. That is the origin.
White Jack.
White Jack.
Okay, I'm gonna look at. It's on Amazon, right? White Jack. Hold on, Morlix. No, it gives me a Jack. It gives me a Jack. It gives me a real Jack.
Yeah.
Okay, hold on.
Dr. Sano fan club.
Thank you.
My mentor that trained me right now, he's a Dr. Sano fan club. So yeah.
Thank you.
I can't find it there. Let me look and hold on. So people can buy it if they want.
Yeah. This is free. I can give you.
Oh, okay. Well, let me find out. White Jack.
Okay, so if
I
anyone
can't find.
books, you can directly message.
You can translate to Chinese, please.
Oh, we can see it. We can see it.
You can send to the Chinese.
Hello, Saeed.
Hello, how are you?
Yeah, I'd like you to meet Dr. Hirotashi Sano. He just gave a great lecture. He's a vascular surgeon from Japan.
Yes, great.
And Saeed is a neurosurgeon from Africa, right, Saeed?
No, from French department in Ocean Indian. It's Reunion, Mauritius.
Oh, you're not in Reunion now?
No, Reunion is not
Oh,
Africa.
okay. Oh, okay. Okay. Very good. Let's see here. See any other news? Warlocks, any other news?
No.
Well, you know, Warlocks, we really got to make some good videos for that app. Think of some stories. But anyways,
I have a question from.
Go ahead.
Yeah, Dr. Sano, like, do you have any tips for drawing operative picture? Dr. Sano, I have a question.
Yes.
Questions from the panelists. He asked, do you have any tips or suggestions for drawing and operative pictures?
No, by myself. Everything by myself.
Well, you can answer that too, Warlocks. How do you do it?
No, I'm gonna answer the same, like by myself. But I have to say that I at the beginning I have to like saw his book and oh my god, it's so nice. I just used the copy paper and put on him, and then like try to draw it. Right after. But my imagination is not as strong as Dr. Sano, so I think right now at the beginning, something I think 20 or 30% of my drawing P-operative will be wrong. So that's bad. So I still practice.
You know, I know Cushing advised drawing, but how many neurosurgeons really do it? And that's really for Dr. Sano and Lorix. Do many neurosurgeons do drawings?
I think so.
I think, yeah, in Japan.
Yeah.
I went there, you know, like in every morning, the residents have to be present their operative picture before too, when I go visit. It is really fun because if they draw really beautiful, they will get a compliment from the teacher. But if the drawing is not very nice, so it's kind of like a joke. The sensei will ask them like, "What's that?" Then they have a discuss. And I love that because it's kind of like a guess. And when you attend the operative, so, and it's like the answer that what you think it's the right thing or not. So yeah, that's really nice. In Japan, I think they do it in many places.
Yes.
Oh, you're still here. That's great. You came back.
Oh, yeah.
You came back, Takashi.
Yeah. I'm doing other things. So after I came back, before surgery, in a university, our residents write operative pictures. I'm not good at writing pictures, so I admire those people, the good pictures. So I try to sometimes I try to study operative pictures.
Yeah.
It just trains your mind, right? It trains your mind to think in 3 dimensions, Morlix and Dr. Sano.
Yes, 3-dimension mind, and yes.
Were you an artist anyways, Dr. Sano, or you just went into it and learned it?
No, by myself. Everything by myself.
Oh, okay,
Yeah.
okay.
So
you weren't professionally trained.
Yes.
Well, that's okay. As long as you can tell the story.
The way that he used the light and the depth and how he used the highlight, it's professional artist.
Yeah, you're speaking like an artist, Rolex, right? You're analyzing it artistically.
From your picture, like the way that you, I mean, I hardly use the yellow color, like, so you use the yellow color mixed with the red one, so it's really shows the atherosclerosis for real. I mean, I hardly
Can you see that? Can you see that? Okay.
No, it's his picture. Actually, it is not his first time. I listened to, I mean, I used to join your webinar before, so I mean, fan club.
Thank you. Okay.
Okay, John, I gotta go.
Okay, very good,
Okay.
Dr. Sao. Great, great. Anytime you want to give a lecture in Japanese or English, let us know.
Yeah, thank you.
Okay, we'll see you everyone next time.
Okay, we see you.
Next time.
Warlick,
Thank
thanks
you.
a lot.
Yeah.
Thanks a lot, Warlick.
Yeah.
Great job.
Thanks a lot.
Bye bye.
Oh, listen, can you
Good
wait,
night.
Takashi? Can you wait a second? Can you wait a second, Takashi?
Yeah.
You have a few minutes?
Minutes? Yeah, just okay. It's okay. Hi.
Yeah. I mean, this is great, man, because
Thank you.
oh, man, it's great. It's great because
Yeah.
now when I get a conference like doing you did a WNFNS and at neuroanatomy. There's another one coming up at the end of January by Dr. Dio Pujari. I think it's on neuroendoscopy. So certainly, if you want to translate that, it's a WFNS.
Okay, so,
it's a big one. It's a big one.
Yes, yeah, many times I translated the WFNS English into Japanese and to introduce, invite more participants, Japanese participants, to help the Japanese residents. Yes.
Oh, excellent. Okay, we'll do that. I'll let you
University, know. Showa University, Tokyo, Japan. I'm studying anytime. I'm specializing in malignant brain tumor. Not only brain tumor surgery, I'm studying the vascular surgery, many other things. So we continue to attend this meeting for keep studying and keep connecting with you all. Thank you.
Right.
So
great.
Yeah, keep in touch.
You know, in Brazil, there's a significant Japanese population. There's a lot of Japanese in Brazil.
Yes.
So that conference that Barbara is doing in February.
So I'm expecting. I'm very interested and exciting.
Yeah, listen, I'm going to give you a WhatsApp number to come into the group that is working on the Brazil project. So it's like it's for people, the technicians, the speakers to talk to each other about the conference informally. And arrangements. And they may talk to you. I bet you other people want to do this too. So, anyways.
Okay, then. Okay.
What do you think of that, Warlick?
I'm very excited.
Yeah, this is great.
Hey,
Warlick, what do you think? We just expanded to Japan. What do you think of that, Warlick?
That's great. I about to study Japanese language.
Oh, really? You're gonna start studying?
It's great. It's good.
Yeah, I have Japanese for Spanish. Okay.
Yeah, so the
hey, there's some other doctors that like to. Hello, Dr. Dr. Capabulo. You want to meet everybody? Capabulo and Dr. Dusembi. Do you want to say hello?
Hello.
Hi, where are you from?
I'm from Uzbekistan.
Uzbekistan.
I trained in Japan. Yes.
Oh, you trained in Japan.
In Japan. Great.
Where'd you train?
And I was a fellow. Yes, I work as a neurosurgeon in Tashkent, and I also was a fellow. Yes, Tashkent. And I also was a fellow of Professor Kato Sensei and Hiroki Kurita from Saitama Medical University. And Dr. Mizuna from Tohoku Hospital in Kanagawa.
Dr. Mizuno, spine surgeon.
Yes, spine surgeon. And
Junichi Mizuno. Yeah, I know him very well also.
Yes. And next year, I think I won a scholarship for 1 year in neuroendoscopy at Nagoya University Hospital.
Nagoya University.
Yes, with the Professor Takuichi. I think I can have an opportunity to visit Sano Sensei's hospital to
please come
to study sometimes.
You see, this is the way that you guys can get fellowships and network and meet people. You can meet them in this and this platform. You can meet them. You can meet someone like Dr. Sano in this.
Yes. I am operating Monday, Tuesday in Shinkabashi and Friday in Aoyama, Toyokawa. Yes, please come.
Toyokawa. Okay.
Thank you.
Anybody else want to say? Let's see, Dr. Sarek, you want to introduce yourself and meet some people? Hi, Dr. Sarek. Just unmute yourself there. Oh, unmute. I'll try to unmute you. There you go. Go ahead. Go ahead.
Hello.
I guess you.
Yes.
Yes.
Yes, I have met Dr. Sano in China.
I'm sorry, I didn't hear. Did you hear that, Warlocks?
Yes, he said that he used to meet Dr. Sano in China before.
Oh, good. Good. Very good. Welcome back.
I studied in Kyoto with Professor Nobuo Hashimoto.
Oh, okay.
Kyoto.
1 year.
Dr. Hashimoto.
Professor Hashimoto. 2005.
2005.
Oh, wow.
Kobe.
Many neurosurgeons go to Japan for fellowships,
Oh,
right?
yes.
Many.
Yeah.
Wow, I'm surprised that people, when you look at their resume and you talk to them, said, yeah, I spent some time in Japan. It's good to have on your background, right, Warlocks?
Yeah, that's very nice, like pleasant stay, really nice weather, beautiful place to travel, and really, they really treat me really nice. Yeah.
Yeah, many cuisine, Japanese cuisines. You can enjoy.
Someone's asking Dr. Sano a question. Abu Bakr Shomo, are you there now? You want to ask him directly, Abu Bakr? Are you there? He has a question about residency, and I'm sure, I don't know if he's still there or not. No, he's not here anymore. Okay. Okay. Very good. Excellent. It's great news with televising in Japanese and Chinese. We got an app.
Okay. Yeah.
Warlocks, we're kicking butt.
Hello.
Okay.
Oh, we got a there he is. Okay, go ahead. Go ahead.
Hello, everybody. Thank you, Professor San, for great presentation, and thank you, John Bennett, for your great regulation of this meeting and for your great effort usually.
My honor.
I'm asking about if there is any possibility for neurosurgery residency in Japan and how to access that for this for the doctor from the Africa.
Africa.
How is that? Are you hearing me?
Yeah. Yes. Maybe Dr. Yoko Kato and some university maybe accept even Africa or Asia, Europe, any part. But you have to accept first. Then.
Okay.
But when you come to Japan, maybe you can come to what my surgery. And but I am moving to operating in all in Japan, so the directly to me is difficult. But maybe you have to accept the Kato's position. Yoko Kato's. Maybe she can arrange to go come to my surgery. Yes.
Yeah. Okay. Deeply thank you, Professor.
Would you advise going there for a month or two, fellowship or something, or rotation? Would that help, you think, Warlocks, if we went to Japan? Do people do that? They do they go for a short time and to look at, to check it out, and then they apply?
Like as Dr. Sano says that they have their regular like operative days, and also the professor have to like go to some other place to do an operations too. Sometimes my teacher like took me to go with him too to operate in another city. So
Yeah.
it made me feel like their style is active. So I think for me, that inspired me after I come back to my country that I'm just not only sitting in the room and waiting for the case. Sometimes just like have to chase for like opportunities and something like that. So they're so active. That's the way that I learned from Japan. And I would like to go in there again. Yeah.
Dr. Sano, someone says you play tennis.
Yes. Yes.
Yeah, I used to play a
Saturday,
lot.
Sunday. Yes.
Oh, the weekends, huh?
Weekend. Yes.
Well, you know, I get frustrated because when I don't play much, I get very bad, very inconsistent. And then I go back and play. I get so mad that I can't do it anymore.
Yes. Yes. Of course, you have to train your body. Otherwise, you cannot turn it of the surgery on anything. So training fast.
Oh man, this is great. This is great, man. It's working, Moralex. It's working.
Okay. I gotta go.
Okay, everybody. Thank you very much, and we'll see you next time. Stay in touch.
See you next time. Bye. Have a nice.
Thank you. Bye. Have a good time. Have a good night.
Happy New Year. Bye.
はい。佐野先生、お疲れ様。